and to be introduced by my senior like you. And definitely, I feel a bit shy to read my credential in front of you, because you have been my senior and rather many time teacher for all these academic activity. So good evening, Varesh sir, and all senior consultant faculty for this evening. And I think a bit early, but then I'll be talking about biomarker based risk prediction of heart failure in diabetes and pre-diabetes. Definitely a very thin line we have when we say that heart failure in pre-diabetes, but then certainly heart failure has been an issue for last several decades, but we have been missing it on of late. And there have been a number of studies and trial which has given a great insight, and biomarkers which can predict it early has a great value. We know that heart failure worldwide has a very heterogeneous presence. If you talk heart failure in European and Western countries, it goes to obesity, it goes to metabolic disorder. And when it comes to our part of world, when Asian countries, it is predominantly due to atherosclerotic cardiovascular disease or at times metabolic disorder. And we also have a very typical type of lean people with metabolic disorder, with high insulin resistance and very, very high risk for developing heart failure. So worldwide, heart failure has a very heterogeneous presence and etiology. And to diagnose it before time, again, has become a very difficult task, but very important not to miss for our patient, because we all understand that our population, especially Asian population, are gifted with several cardiovascular disease with increased inflammatory mediated damage to endothelium, which goes not only to atherosclerotic part of disease, as well as it also comes with the heart failure issue. So definitely a person who is the diabetic has double the risk of developing it. And in a Framingham heart study, which was done in a large number of population, showed that heart failure was 2-fold high in men and 5-fold high in women. So again, our female population is of much higher risk, and we should have some specific biomarkers which can predict it early and can be of great value in terms of diagnosing heart failure. So increased incidence of heart failure in diabetes may persist, or there are factors which is like age, hypertension, and dyslipidemia and coronary artery disease. But diabetes itself, it becomes a very important risk to keep in mind in a patient with those who comes to us. And pre-diabetes is also not a case where we have all those issues what we deal with metabolic disorders like pro-inflammatory cytokines, endothelial dysfunction, and associated increased risk of stroke, peripheral vascular disease, and myocardial infarction, and heart failure also becomes a part of high risk cases when we diagnose a person with pre-diabetes. So we should have our eyes open and look for those high risk cases and try to diagnose what I'm going to discuss with what are the biomarkers which can be of a help in diagnosing heart failure in a very early stage, or even before we pick it up with symptoms or other issues. I think we are all aware of an NYHA classification of heart failure staging, and what I was worried is those cases with high risk without symptom have a very important to be diagnosed with the hypertension, CAD, and other risk factor like family history of cardiomyopathy or diabetes, which is of particular importance to my topic. So these staging gives us a fair amount of idea that how severe is the disease, but picking it up in the early part, we need help of different indices. We know that diabetes has a very high cardiovascular risk due to several mechanisms associated with oxidative stress, ultimately leading to fibrosis, necrosis, apoptosis, and several biomechanical damage to different structure of body, which include all vital organs and all endothelial structure of body. So diabetes with high cardiovascular risk have a number of mechanisms, and when we want to discuss particularly with heart failure, we have to look at the damage at the level of myocardium, damage at the level of renals, at the level of endothelium. So if we take as a myocardial injury, we have biomarkers like troponin, cytokinin, and H-type fatty acid binding proteins. And if you look at the chamber dilatation with the ventricular hypertrophy or myocardial stretch, we have a nitrouretic peptides, which I will be discussing in detail. And we have a renal injury associated markers like creatinine, cystatin C, and electrolytes and NGAL. And when it comes to inflammatory markers, we have hs-CRP, interleukin 6. We have suppression of tumorigenicity 2 factor. We have TNF-alpha and procalcitonin, and fibrosis associated factor like ST2, galactine. And there are a number of new markers which is under development, and we will be learning it shortly. But at present, we have a very important markers like H-type FABP and cardiac troponins, which are much significance at current scenario. And we also have nitrouretic peptides, which I'll be discussing in little detail to diagnose heart failure in early cases where we don't have much of a clue, and these can help our patients. When it comes to nitrouretic peptides, we know that nitrouretic peptides have immense systemic homeostatic effect, playing a pivotal role in regulation of natriuresis, electrolyte and water balance, vascular permeability and vasodilatation. Cardiac contractility is very much controlled by these peptides, and related blood pressure changes, which we can see whenever there is changes in these peptide levels. So nitrouretic peptides are physiological antagonists of renin, aldosterone, and its congener. Then we have different types of nitrouretic peptides. We all have seen this from our physiology days as atrial nitrouretic peptides and brain type nitrouretic peptides and C type. So in that, B type is of much clinical importance, and I'll be presenting about these details. So clinically, in current scenario, these markers have been very well studied and have been recommended that it is helpful in diagnosis of heart failure and stratifying patients who are at higher risk of developing either heart failure or even hospitalization for heart failure and future admissions. And they are very important when patients are asymptomatic, as well as those patients with symptomatic heart failure. They can be stratified as high risk, and they have high risk for overall of cardiac mortality or death when they have high level of N-type pro-BNP level around 125, which I'll be again discussing. And natriuretic peptide in heart failure with HFrEF, patient with prediabetes and diabetes both have independently predictor of atherosclerotic atrial fibrillation and pulmonary hypertension. So there are a lot of information which can be gathered when we estimate these peptides and get a clue about the prognosis of the patient. When it comes to cardiac troponins, we have again excellent markers which can predict myocardial injury, myocardial necrosis, and adverse outcome when it comes to, again, pre-diabetic and diabetic patients with cardiac injuries. Patient with these with pre-diabetes and diabetes may develop asymptomatic MI, which is again a very dreaded complication, and we do have number of cases, especially when it comes to our population with thin coronary arteries and a very early onset of cardiac damage. These markers can be of great value to diagnose this silent disease. Patients with metabolic syndrome have demonstrated that high level of high sensitive cardiac troponin I level than those who do not have the condition. So these troponins, as well as a high sensitive cardiac troponin T, are also a similar predictive value when it comes to CV death or increased measures adverse cardiovascular event and heart failure. So considering the high availability of these measures in around us, this becomes a significant tool to not only prognostic as well as diagnostic value for a patient who have these cardiac injuries. Increased level of NT-pro-BNP in patient with diabetes has increased risk of heart failure, which was studied and clearly demonstrated in our advanced trial, which have been discussed. That 12-fold increased risk of heart failure was found in those population where NT-pro-BNP was compared higher than the other thing. There are 3-fold increased risk of heart failure also seen in patient with diabetes with 1 standard deviation of NT-pro-BNP level. So high value of these marker is of significant value if we have to diagnose risk for heart failure or those who can develop in future. Prognostic value of NT-pro-BNP level have been also seen recently in very depth in a paradigm heart failure studies, which has been a marker for high risk cases for heart failure, and level of NT-pro-BNP level was associated with increased risk of CV death and heart failure hospitalization by 3-fold if they have patient with HFrEF, patient with presented with diabetes. So diabetes with the HFrEF and the markers have shown a clear-cut indication in diagnosis of hospitalization for heart failure or CV death in paradigm heart failure studies as well. There is another indicator which can be seen as hard type fatty acid binding protein, where these are a novel biomarker to diagnose early MI or injuries associated with the CV disease. So hard type fatty acid binding protein is associated and released by cardiac myocytes after a non-selective increase in cell membrane permeability and cardiac injury. So circulating levels are also found higher in pre-diabetes and diabetic patients. So we traditionally used to diagnose all these issues with diabetic patients, but on discussing these markers, even pre-diabetic patient can be picked up quite early and can be prevented in long term. So these markers have a great role when we are going to see it in practice in coming days. There's another marker like soluble suppression tumorigenicity 2, which is again not commonly available, but these are a decoy receptor of interleukin 33, which has inhibition of effect of interleukin 33 ST2 ligand signaling. And these are produced by endothelial and epithelial cells and fibroblasts with certain immune cells. And they have a very high predictive value for cardiovascular disease and event, including heart failure. So measurement of these indicators can have early diagnosis and we can plan accordingly once we diagnose the high risk cases. Another factor is growth differentiation factor 15, which belongs to transforming growth factor B superfamily, and they also have a very high level when when there is a diabetes with pre-diabetes and diabetes with healthy compared to healthy volunteer. So elevated level is predictor of adverse cardiac remodeling and poor prognosis for heart failure. So there are a number of factors which can come in help of diagnosing either cardiac related biomechanical stress, or maybe a cardiac myocyte necrosis, or maybe related to inflammation, which are the basic of all damage which happens in cardiomyocyte. So defining these levels and correlating it in patient with diabetes and pre-diabetes has great value when we want to diagnose. And in the multivariate adjusted associated biomarker have been associated with independently with high heart failure and increased risk for developing hospitalization. So there is a study by Ambrish Pandey and group, which also include Mikhail Kasiport, where they studied biomarker-based risk prediction for heart failure in pre-diabetic and diabetes. And they also this was a larger study where they looked for the different markers in condition where they took participants those were having free of cardiovascular disease from 3 cohort study from ERIC DHS and MESA trial, and they could demonstrate that a significant graded association was observed between the different biomarkers group with high risk for heart failure in diabetes and pre-diabetes, which are independent of other factors like age of disease and other co-founder and variables. So definitely studying of such markers can go a long way when we want to diagnose. And once we have diagnosed, there is a clear-cut benefit of using the newer molecules like SGLT2 inhibitors and ARNI, which can be of great value. A patient with diabetes, if you can demonstrate having a higher level of high sensitive cardiac troponin T of more than 6, a level of NT-pro-BNP level of more than 125, and high sensitive CRP of more than 3, and you can also have a predictor of LVH in ECG, can give you a clear-cut early diagnosis for having heart failure risk and cardiovascular disease, and use of SGLT2 can reduce and mitigate the risk in those cases who have been diagnosed early. And if you see in the study by the group, they have shown that use of SGLT2 can significantly reduce the risk of heart failure in 1,000 participants in 5 years, when they have stratified as very low, low, intermediate, and high risk, depending on the value of these markers, and they can get a clear-cut benefit in reducing the cases of heart failure. If we see different SGLT2 inhibitors, when we have defined the different markers, then I was asked to find out which SGLT2 has what benefit. And if you see this forest plot by Jinman and group, which clearly defines that all the molecules so far which we have studied, from IMPA-REC to CANVAS, DECLARE, CREDENCE, and to VERTIS CV as well, most of the molecule, almost all the molecules have shown benefit in terms of reducing hospitalization for heart failure, either in patient with confirmed atherosclerotic cardiovascular disease, and they have shown benefit in terms of reducing hospitalization for heart failure. If you take a net benefit of SGLT2 inhibitors across the disease, like patient with diabetes with no other severe risk factor, there has been a number of trials which include DAPA-HF, and those cases with the high severe risk, which has been studied extensively in CANVAS and DECLARE-TB, diabetes with established atherosclerotic cardiovascular disease, which has been studied in IMPA-REC, DECLARE-TB, CANVAS, cases with a high CVD is in CREDENCE and DAPA-HF, and patient with or without diabetes as well has been studied in DAPA-HF, deliver and emperor preserve, emperor reduce and Solace trial. All across the trial, one thing was consistent, that they did show benefit in terms of reducing heart failure, and they did have cardiovascular benefit to a large extent, with the reduced risk of death overall. So the cardioprotective mechanism of hs-cTnT inhibitor, I think I'm not going to read everything, but we know that there have been number of postulation which can give rise, which has given a number of benefit in terms of reducing improvement in ischemic reperfusion injury, in terms of reducing prevention of increased NT-pro-BNP level, and there is an increased adipokinin level and decreased epithelial adipose tissue, and so on. So most of the SGLT2 inhibitors have been working at some level where they did have a cardioprotective benefit, and because of that, ESC guideline in collaboration with ESD in 2019, they have given a guideline where in a patient with diabetes, even if they are drug naive, they can be prescribed SGLT2 inhibitor or GLP-1 receptor agonist in terms of those with high atherosclerotic cardiovascular disease or with high CV risks or high risk for developing heart failure. And later on, if your patient is already on metformin as well, they have first choice as SGLT2 and GLP-1 receptor agonist. And if you see ESC guideline, the recommendation for use of SGLT2 inhibitor as IMPA in cases of high risk of atherosclerotic cardiovascular disease, IMPA, CANA, and DAPA has been given as recommendation of class A and level A recommendation for use of these drugs. Even if it comes to heart failure, then we have again the recommendation of IMPA, CANA, and DAPA at a level of class 1 and level A recommendations. So most of the guideline has included, and I think this is very important to find out potential framework for identifying patient with baseline of heart failure or established atherosclerotic cardiovascular disease, and how and when we should start SGLT2 inhibitor, and those are the patient can get benefit of uses of SGLT2 inhibitors. We have cases where diabetes specific risk factor are there, like long term of diabetes for more than 10 years. If a patient with non-optimal glycemic control of HbA1c of more than 7, and those with microvascular disease, they are at very high risk. And at least those patients who are on insulin or sulfonylureas or thiazolidine uses can have diabetes specific risk factor for developing heart failure. And saxagliptin use of DPP4 also have been included in the risk factor for developing heart failure. So these are the high risk when it comes to diabetes. And when it comes to cardiovascular risk, we have hypertension, obesity, and atrial fibrillation. And if you want to see non-cardiac risk factor, it is age and again obstructive sleep apnea. These are the risk factor where we have to do estimation of NT-pro-BNP level. And if it is more than 50, between 150 to 50 to 124, there is a recommendation of use of SGLT2 inhibitor if at all patient needs to be used. And those patients with high level of NT-pro-BNP of more than 125, you have to consider using EPO and consider structural heart disease and other factor also associated with this conditions. So to conclude, I'll say that the estimation of number of heart failure, even that can be